Unfortunately, research on the lived experience of those with Ehlers-Danlos Syndrome, or EDS, shows us that we as occupational therapy professionals need to do a better job working with these individuals. People with Ehlers-Danlos Syndrome report that they struggle to find reliable information related to their condition, experience social stigma from their peers, and just see this general lack of awareness about EDS in the healthcare community. As occupational therapy professionals, we can contribute so much to supporting this population. Today, we are going to look at a self-management program grounded in behavior change theory that was co-designed by people with lived EDS experience. After we look at this article, we will welcome to the podcast a returning guest, Emily Rich, PhD, OTRL. Emily is an occupational therapist who has EDS and treats EDS clients in her clinical practice. Emily and I will discuss best practices for EDS self-management, assessment, and treatment. So let's dive in. Welcome to the OT Potential Podcast, where we review new and influential OT journal articles, then invite an expert guest to help us pull out actionable takeaways that you can implement in your practice starting today. Welcome to the podcast. I'm your host, Sarah Lyon, OTRL. And before we dive into this topic of OT and Ehlers-Danlos Syndrome, I wanted to let you know that this podcast may qualify as continuing education for you. You are probably listening to this podcast on a free podcast platform, but to gain CEU credit, you will need to be a member of the OT Potential Club, our OT evidence-based practice community. Bearing in mind that this could count as a CEU course, I wanted to state our 2 learning objectives so you can be thinking about them throughout the podcast today. Our first learning objective is you will be able to identify assessments that OTs can utilize with EDS clients. And our second learning objective is you will be able to recognize both traditional and emerging treatment approaches for EDS. So let's begin by looking at this journal article, and then we will patch on Emily to discuss how this research could play out in your practice. The article that we are reviewing today is called Developing a Self-Management Intervention to Manage Hypermobility Spectrum Disorders, or HSD, and Hypermobile Ehlers-Danlos Syndrome, or HEDS, an analysis informed by behavior change theory. This article was found in the Journal of Disability and Rehabilitation, and it was published in 2021. So the article begins with this big picture intro to Ehlers-Danlos and hypermobility spectrum disorder. So hypermobility spectrum disorders, or HSD, and hypermobile Ehlers-Danlos syndrome, or HEDS, are heritable connective tissue disorders that are characterized by chronic joint pain, muscle pain, and multi-system symptoms. So while hypermobile EDS and HSD do have these distinct diagnostic criteria, which I will link to in our show notes, I want to note that the Ehlers-Danlos Society's current management advice is the same for both conditions. And I also want to mention that hypermobile Ehlers-Danlos syndrome is only one of 13 types of EDS, but it is the most common. There's quite a bit to read about the different diagnostic criteria, and I will link to this in our show notes, and Emily and I will discuss it briefly as well. But back to the article, poorly managed EDS can lead to muscle deconditioning, fear of injury and pain, reliance on emergency care, and in both EDS and HSD, poor management of symptoms can lead to substantial emotional issues, including low confidence, anxiety, depression, and social isolation. So what is the current treatment for these conditions? There is no cure for EDS, and there has yet to be any high-quality research focused on helping this population overcome the challenges that they commonly experience in daily life. But that being said, the current research does tell us that patients with HSD and EDS would like to receive greater support and guidance in managing their condition. Currently, self-management is a mainstay of treatment for both HSD and EDS. But compared to the robust patient education and self-management recommendations that are available for individuals with other musculoskeletal conditions, HSD and EDS patients receive very little guidance and support. So from here in the intro, the authors go into this background on behavior change and self-management programs. So according to recent research that explores self-management programs, interventions that are underpinned by psychological theories are more effective than those that are not. In line with this best practice, the study that we are looking at today, which is going to focus on building recommendations for HSD/EDS in a self-management program for them. These recommendations are going to be underpinned by two psychological theories, the theoretical domains framework and the capability motivation behavior model. I will link to both those in our show notes. Okay, so that's all kind of the background info about these two conditions, about where we stand on self-management program. So now we're going ahead into the intent of this research. The authors sought to determine recommendations for an HSD/hypermobile Ehlers-Danlos Syndrome self-management intervention. And they went to develop this self-management intervention in 3 stages. First, the researchers conducted a behavioral analysis. In this stage, the authors sought to triangulate data from multiple sources with an emphasis on firsthand information gathered from the patients themselves. A systematic review of literature involving the lived experience of EDS was conducted, and the findings were actually published in a separate paper, which I will link to. And on top of that, 17 semi-structured phone interviews were also conducted to gather firsthand information about the psychological impact of the syndrome. And those findings were also published in another paper that I will link to. So using these 2 papers, the authors identified barriers and challenges to daily living and then map them to specific behavior change techniques that fell under different categories of that theoretical domains framework. And doing this, they were able to identify 41 different potential behavior change techniques that could possibly be included in a self-management program. So once they got these 41 possible techniques for the self-management program, they headed into stage 2 of this study. And in stage 2, a focus group of researchers refined the list down even farther that would then be presented to people with lived experience of EDS. So this focus group comprised research with expertise in qualitative research and in behavior change frameworks. They refined the list down from 41 to 20 potential behavior change techniques. And then in the final stage of this paper, the authors used a nominal group technique, where 9 people with lived experience of HSD/hypermobile Ehlers-Danlos Syndrome rated the importance of each behavior change technique. So this nominal group technique is a highly structured group process that ensures that all voices in the group are heard and valued. The group rated each previously identified behavior change technique and had the opportunity to suggest new ones. Ultimately, they arrived at a final list of 14 behavior change techniques that they felt were important to be included in a self-management program. So after those 3 stages, what were their results? I'm going to share the 14 behavior change techniques that were deemed the most important to include in a self-management program for clients with HSD and hypermobile Ehlers-Danlos syndrome. They also fall in these kind of broad buckets, beginning with education. So the first behavior change technique was education to help patients understand their syndrome, manage pain, deploy self-help measures, and cope with fears about decline. The second was educational examples of management behaviors, including self-help strategies for coping with injury and pain. The third was educational programs with a focus on self-help and coping strategies for injury or pain. The fourth was education on the consequences of overexertion and exacerbation of pain and fatigue. The fifth was guidance on how to evaluate information related to these syndromes. The sixth was templates outlining examples of increased symptoms during pregnancy and what to do in each scenario. The seventh behavior change technique was guidance on how to find trusted and accurate sources of information for these syndromes. And eighth was education to help patients navigate social support resources. So that's kind of the education bucket, which is the majority of the behavior change techniques. Next is skills development. The people with lived experience felt that skills development training for patients focus on advocacy, assertiveness, and communication to improve the interpersonal communication of their needs was important. The 10th behavior change technique was training and pacing skills to help individuals learn how to actively manage cycles of activity and rest, ultimately increasing their participation in daily activities. 11th was, again, improved education, training, and information for participants regarding what to expect during pregnancy. Okay, we're getting close to the end of this list of 14 recommendations, but there's 2 more categories left. One is environmental restructuring. The 12th behavior change technique that fell under this category was strategies for altering the physical environment with occupational therapy input to help patients accomplish tasks independently. The 13th behavior change technique was access to emotional support, like mindfulness training, counseling, CBT, or educational books. And the last bucket has our last recommendation, which is modeling, specifically positive first-person modeling narratives that address some of the negative aspects of these syndromes, such as depression, distress, frustration, sexual dysfunction, and feeling of loss, and how patients have successfully coped with these effects. Okay, so that was the results and their 14 recommendations for what to include in a self-management program. Heading into their discussion section, the discussion section of the full article really fleshes out the literature around each of these 14 takeaways. But 3 things I want to highlight for occupational therapy professionals are that education is clearly a central part of self-management, as patients require the knowledge and skills in order to successfully manage their own condition. Another important underlying component of self-management is acceptance of the syndrome. In conditions associated with chronic pain, acceptance can be a predictor of successful self-management. And lastly, one suggestion that stood out to me in this discussion was to help patients claim the agency to self-manage their condition by giving them the ability to self-refer to treatments like physical therapy. So headed into the final conclusion, the authors share that in summary, this study provides valuable insight into what patients with HSD and hypermobile EDS would like to see in a self-management intervention. Future research could develop supporting materials to allow for effective delivery of behavior change techniques. Okay, that was honestly a pretty complicated article, how it moved in these 3 stages and arrived at these 14 suggestions, but it feels worth that journey to really be able to hear from the people with lived experience of EDS and what they would like to see from treatment and what's important to them. I think I left the article with a better understanding of EDS and some of the things that would be important to patients. But I don't think I fully left knowing what I would do as an occupational therapy professional as one of these patients would walk through my doors. And that's why I'm so thankful to be having our guest today to just really talk through the practical implications for your occupational therapy services. Emily Rich, PhD, OTRL, is a researcher and clinical specialist in postural orthostatic tachycardia syndrome, or POTS, and Ehlers-Danlos Syndrome / joint hypermobility. Emily's research centers around POTS and rehabilitation therapy, specifically exploring self-management and group-based treatment options. As a clinician, Emily specializes in treating individuals with chronic conditions, including forms of dysautonomia, such as POTS and Ehlers-Danlos syndrome and joint hypermobility. She places a high value on patient-partnered, evidence-based treatment. So without further ado, I will patch Emily into this podcast. Welcome to the podcast, Emily. It's great to have you.
Thanks so much for having me, Sarah. I'm excited to be here.
Oh, I am so thankful you are back. Just like on our previous episode of POTS, there is so much research yet to be done for this condition. But at the same time, there is so much that we as OTs can do, that we are uniquely positioned to do, that other professions are not doing. There's just a lot to cover. We, in the previous podcast, talked a little bit about your story, about your experience with POTS. What we didn't touch on much is you also have EDS, and I think that's where I wanted to start us today, just as someone with the lived experience of this condition. What do you want us to know about how that's intersected with your story and just what you want people to know about living with EDS?
Yeah, Absolutely. I love that you are working on getting more people with lived experience because, as a clinician, I had never intended to see this population. This wasn't my plan for my work. But as you mentioned, I have hypermobile Ehlers-Danlos syndrome and just saw and experienced myself, but then saw in the population like these people needed help. And even though I didn't have explicit training in this condition, as most OTs don't, I realized that I could do something to help them. And so I needed to do it. So in terms of what, my experience, how that informs maybe my work or what I would want other OTs to know, I would want to share that it can be really invisible. It can be lonely and it can be really confusing. Most of these patients, myself included, have been told, that it's in their head or that it's just anxiety, similar to POTS. Maybe you're having growing pains and that's why you've had pain your whole life. And that doesn't make sense, but that's, what a lot of people are told. These are growing pains. Or when women, a lot of young women start to get these symptoms in adolescence and they're told, it's just part of puberty or it's just hormones. And so understanding that when a patient gets to your door, they've already likely had a long road to get there. And it's taken, a long time to get a diagnosis, to get answers, and then even longer to get in to see a therapist. And so there's a lot of mistrust. There's been a lot of medical gaslighting, most likely. And many times, if they've seen a physical therapist, it's made them feel worse. If they were treated like they had an injury or an orthopedic condition, they were pushed, and it's different. It's different the way that we approach this. And so that's what I would want a therapist to know before they saw this patient is if they do look like they have mental health overlay, it's probably because they do, and it's not because they're crazy. It's because the system, the medical system, things have been really hard for them and they haven't had answers. So they're lucky to be there to see you, but they might not know that yet.
Mm-hmm. I mean, every condition that we see has so much complexity, but as I'm reading about Ehlers-Danlos and like all the different subtypes, what do I need to know as a therapist about the different presentations of it? Like, do most of the clients that you see know what subtype they have? And then what do I need to know as a therapist? It was honestly a lot to wrap my mind around to be like, here's all these different subtypes and here's how this is similar but different from hypermobility spectrum disorder. Yeah, what do we need to know about the details?
Yeah. So if you are a general clinician seeing one of these patients in a community setting, not at a specialty clinic, it is most likely that you're going to see patients with hypermobility, joint hypermobility, symptomatic joint hypermobility, that don't have a diagnosis. You're going to see those patients, I can almost guarantee you, in a 5-year span that you'd see at least one. So know that they might not have a diagnosis. If they do have a diagnosis and it's Ehlers-Danlos syndrome, more than likely it's hypermobile Ehlers-Danlos syndrome. But it is really important to know and to find out for yourself. There is vascular Ehlers-Danlos, which is a life-limiting form, and you really have to be careful about exercise and what you're doing with those patients. Classical EDS is the second most common type. And it's very similar to the hypermobile presentation. So the patient should know what type they have. I would say that's pretty, more often than not, they're going to know. But more often what you'll see is someone who's just been told, I'm hypermobile, or they haven't been told anything at all. And so that's when we need to help them with, do you need to get referred for genetic testing? Do you need to see a specialist? We need to rule some things out. And usually I would argue, yes, they should see someone. There's definitely barriers with finances and having access to knowledgeable clinicians near you. But knowing that, there's a lot of comorbidities, there's a lot of other things that can present. And so if a patient can get a diagnosis, that I think that's helpful for them. But even just empowering them with, it doesn't matter to me if you have hypermobile Ehlers-Danlos syndrome or if you have hypermobility spectrum disorder. It's just a matter of semantics at this point. It's the diagnostic criteria are different, but the diagnostic criteria are changing, and they're likely going to change very soon. So, and then just knowing that there is a genetic a known gene for all of the other types of Ehlers-Danlos, except the most common, which we're going to be talking about today, which is hypermobile Ehlers-Danlos syndrome. So whether people need to get genetic testing is really a conversation to have with a specialist, but many times it's actually just trying to rule out the other forms of Ehlers-Danlos. So I think those are the main things that you need to know when it comes to those things.
You're a unique therapist, Emily, because you have these conditions. You're seeing patients who also have these conditions, and you're a researcher. I'm curious what your current caseload looks like. Is it mostly POTS? Is it mostly EDS? Is it the combination? And I'm also curious what's in your research brain right now that you're like wanting to dig into more and maybe actively digging into.
Absolutely. So it's a unique situation. I would tell you that I think most people have learned not to share anything about their personal health issues or personal health with their patients, and it's been a journey of learning how to straddle that line. I'm now so public about it on social media and things that it's hard. Patients most often know when they come in the clinic. So most of the patients I see me because they saw me online, they heard about me, or their doctor referred them to me specifically, or to our clinic specifically. And so most of the patients I see have either hypermobility of some form, HSD or HEDS, or POTS, but more than anything else, they have both. And whether they know they have both, that just depends. Often they have one in their chart. They come to me and they've heard they might, and I'm like, yes, we need to pursue this. You need to understand why these things are happening to you. I want you to understand this better. So, and the other thing that goes with those is mast cell activation syndrome, which many of my patients have. So that is most of my caseload. However, I don't work in the clinic 40 hours a week, which I'm grateful for at this point because it's a challenging population to only be seeing that in that volume. But that is majority of what I see. Over 90% of my patients have those conditions, and there's a high overlap between them. And then I do research too. So I just finished my PhD, but my research was in POTS, and now I'm getting more into some EDS research that's similar to my POTS work that I just finished. But constantly, my research brain is trying to understand how to help patients have access to information to help themselves, and how to help therapists and clinicians know what is most effective that they can do to help these patients. Because I know that therapists are overwhelmed, therapists don't have the training always, or they just have a bare minimum of training, and this population really needs help, and they need it efficiently. They only have so much energy and so much time and expense, financially, that they can give. So that's kind of big picture, looking at, what is it that we can do as occupational therapists, but really rehab providers as a whole, to help maximize these patients' quality of life and their function.
Mm-hmm. I see how well positioned you are to look at the specific article that we covered today about this self-management program that had all this patient input, really focused on behavior change, setting that client up for success. I learned a lot reading it. What stood out to you, though, from your clinical perspective and your research perspective?
Yeah, I love this article. I love Sarah Bennett. She's an occupational therapist, and this was her PhD work. And so I just respect what she found so much because I know so much heart and time and work went into it. And so several things stood out to me. Much of the EDS literature is kind of the same. They find the same things, and it's good because it's reinforcing, right? You're saying we're finding the same thing from multiple group cohorts of people. But she found several things that I haven't seen talked about enough. And one of those is pregnancy. So one reason I'm curious about it and interested is because I had a baby last year, and it's an area that there is very little information about. And I have been speaking more about my experience on social media, but very cautiously and carefully. And the response has been insane. The number of people who are like, help, please. Yes. Like, talk more about this. I can't find help anywhere. And so there's a challenge with EDS and pregnancy because it is a genetic condition. It can be passed on. And so there's a lot of feelings around that, a lot of moral and ethical challenges. And each person has their own journey of getting to a place with it and making decisions for themselves. But Dr. Bennett found this importance of what do we need to expect during pregnancy? How do you model coping strategies from other moms? So how can we as OTs, I'm like, yes, how can we help put people together and give experiences from other patients that we've seen or, work with pelvic floor therapists? And then developing templates outlining examples of increased symptoms during pregnancy and what support tools exist. It's like, we need this so much. Mostly there's more literature in the midwives. There's a midwife and a group in Europe who has a website, and they've done some really good stuff, but it's just not made its way to therapy. Yet every pelvic floor therapist will tell you they're seeing these patients in, huge numbers. So that was a big one for me. I think OT has a huge role in that, in not just pregnancy, but postpartum and parenting and all of that. So, and then also I love that she found, this importance of assertiveness and communication skills, because this I see all the time. I think we are taught how to work on this in OT school to a degree, but it's definitely a more unique skill set that a chronic illness specific therapist is, using. And so these patients are told it's all in their head, or the specialists say, this isn't in my wheelhouse. You need to go to this specialist and this specialist. And patients are left with, what is going on with me? It must be something horrible because all these people are saying that it's beyond what they're able to help. So how do we help them help themselves and help providers to help them by empowering them with effective and assertive communication strategies, because that will last much longer than the time that they're seeing us. That will carry through the rest of their life, hopefully, and their other encounters with healthcare providers. I also really liked how she talked about the importance of judging information and getting good quality information. So providing guidance for patients on where they can get trusted, accurate information. And then they also use the word protect from unreliable information. In this era, 2024, it's just insane how much bad information is out there, especially for populations like this, where people are trying to capitalize on a vulnerable population, and they're trying to get them to buy the next supplement or take the next class that's going to help cure them. And there just is not a cure. And so really helping patients to know when to bite and when to say, well, this has red flags for me. What do I need to look for to make sure this is trustworthy information? Because again, that's going to carry through far beyond your course of care with them, so that when they get another diagnosis or another symptom comes up, they can look and get that information. And then lastly, I would say this, the psychological supports that she talked about, how that's needed and it's missing. So many times patients come to me, they're afraid of going to a therapist, a psychotherapist. They eventually want to see a therapist, hopefully after they've been seeing me, because I encourage that, that this is real, this is not in your head. I give them some of the language to help with that. And I encourage them to really give themselves the gift or the basic human right of being able to process what they've experienced. But it's scary. They feel like they can't trust someone, and a lot of the therapists don't have that knowledge. And so we get to bridge that. We get to be mental health providers to the degree that, OTs feel comfortable, and working on things like interoception and sensory processing and body image, kinesiophobia, like looking at yourself in the mirror. There's a lot of challenges and differences, I would say, in body perception and beliefs about their body. And so we get to work on a lot of those things with the patients if we're prepared to go there. And then also just helping to guide them if they need more of that to a provider that hopefully will be helpful.
Could totally, as you're mentioning these different areas, just feel that input of the people with lived experiences. I think historically, I don't know, we just tend towards like exercise programs and easy to measure things. But the things you're talking about are such like heart issues and so important for our patients, pregnancy, going to a doctor's office and not feeling terrible because of how they treated you, like feeling like you were assertive in that communication. These are so like important for us to hold in our heads as we're seeing these patients. I want to get into the logistics though of what that looks like. Like I'm hearing all those things, but I'm like, what do I really do when a patient walks through the door? Like, and I just want to get insight into what you're doing, kind of throughout the assessment intervention process. And start with assessment. As you have a new patient come to your caseload, what are you thinking about as far as assessment? Are there specific assessments that you're using? Yeah, let's start there.
Yeah, so I'm going to be boring and say the same thing that I said for our POTS podcast, which is I use the COPM, the Canadian Occupational Performance Measure, for all these patients. And I think what you just said kind of backs up why it is that I do that. I imagine there are other things out there. Maybe there are other things in the works to better capture some of the medical gaslighting and the trauma and the challenges uniquely with those kinds of things. But for now, what I use in OT is the COPM. And the reason why is it allows me to listen. It allows me to open the door with a semi-structured interview and say, I hear all of these things are challenging. I start with basically our practice framework. Like, how are you doing with dressing? Not a problem. How are you doing with toileting? Oh, I've got urinary urgency or, whatever. Okay, maybe we need to send you to pelvic floor. We go through those and then we say, all right, what is the most important thing? Like, some things are not a problem. Maybe driving isn't an issue for you, but your ability to take your child after school to go do this thing, like that is really hard for you, that occupation, and then understanding why that's challenging for them. So my assessment is really a lot of dialogue and information gathering, especially that first visit, establishing rapport, building that therapeutic alliance. And that allows me to actually treat what's important to them and the things that have been ignored, maybe things that they've never even shared with a provider because it didn't feel important or it didn't feel safe. So I like the COPM. It gives me some numbers. Of course, they are subjective, but it gives me some numbers for intake and outcomes. And then I might do something like a grip strength test with the dynamometer. I do that, relatively often if especially we're working on pain or upper extremity function, which is common. I might use the Moberg pickup test or something like that to look at fine motor skills, maybe like a 9-hole peg. I don't use that a whole lot, to be honest, but if you're feeling like you really need some more objective fine motor kinds of things, those are some ideas. I definitely do, functional range of motion. I'm watching them when they first come in the door and just making sure, are they limiting themselves because of kinesiophobia or because of subluxations, dislocations? Some people believe they're all hypermobile, so they definitely have full range of motion everywhere. But oftentimes there's actually quite a few limitations because of fear of dislocating or, those self-inflicted limitations because they're have had pain. And then I might do like some self-report questionnaires, like the quick dash for upper extremity or fatigue indexes. I tend to use the MFIS, the Modified Fatigue Impact Scale, but I know that there was article cited in this article that they mentioned a multidimensional fatigue inventory that we were chatting about. I haven't used that. And then interestingly, they use a kinesiophobia assessment, the Tampa scale for kinesiophobia. So that's something I'm definitely going to be looking into because kinesiophobia is huge. I also sometimes use like a sensory processing measure, do some interoceptive awareness, questions. I might not do a full assessment. A lot of what I'm doing, fortunately or unfortunately, is looking at medical symptoms that have been ignored or not addressed and saying, this might fall into this bucket. I want you to go see this specialist, and really trying to just kind of help them pare down what can feel so huge, so all encompassing to say, no, this is all hypermobile EDS. You might have some conditions that fall under that, or this is something that's a red flag, and I think you need to go see somebody for that. So, yeah, a lot of information gathering and really just trying to understand what is going on with this specific person in front of me, because they're definitely not all the same by any means.
I see how gathering that subjective information and really listening to the client really counters the gaslighting that they may have experienced. So, how important it is to take that time to listen. And as a generalist OT, I feel encouraged because, like, the COPM is in all of our wheelhouse. Like, listening is something that we can all do. As you're looking to set goals with these clients, do you find yourself gravitating towards certain kinds of goals? I think thinking of this paper that was so geared towards self-management, is that kind of where all the goals are headed towards that ultimate self-management ideal? Yeah. How do you think about goal setting?
For me, yes. For me, it is all about self-management. I don't tell my patients that on the first session
Yeah.
because a lot of times it's hard to hear. And a lot of people are seeing a physical therapist or have seen PT in the past, and they love the fact that their PT, quote unquote, puts their joints back into place. Or fixes them. They have to go into the chiropractor for an adjustment. And they're sometimes looking for that from me. And I'm really flipping the script and saying, oh no, I am not going to fix you. And you don't need fixing, by the way, but you might need some tools. You might need some strategies, and you might need some support, right? You might need someone to come alongside you and do this together. And so, self-management to me is the goal. And I actually tell patients often from the beginning on the evaluation day, I don't want you to see me for a long period of time. Like, we are looking at this kind of a framework, maybe 3 months or whatever it is that they need. And then you can always come back. But my hope is that you learn strategies that then you carry over and you generalize and you do these things for yourself. So my goals typically fall into buckets like creating strategies that they'll be able to name, identify, utilize, some form of strategies for energy management, for example, like strategies for pacing and energy conservation, because fatigue is a big deal. Similarly, strategies for joint protection, right? So that they will be able to go into a task. Maybe it is something in the kitchen. The kitchen can be hard for their hands. And they will be able to say, if I build up the handles, if I position things strategically in my kitchen, use ergonomic practices, whatever devices we've figured out, that then I will be better, more successful in this task. And then hopefully that generalizes to other things like bathing, driving, and mobility and other things. So energy, joint protection, movement practices, it's huge. And I intentionally say movement instead of exercise because exercise can be scary for a lot of these patients. And so finding movement practices that feel good and that they are able to be consistent with and follow through on. So my real goal is let's get you into a community program, whether that is videos online, a subscription-based membership program, or YouTube videos, or there's a Pilates instructor in town who I know, and she would, you can start with them while you're seeing me, and then we'll see how it goes and if you can continue with them, those kinds of things. But it's less of, I'm going to give you an exercise program, or I'm going to measure that from this point to this point. I don't focus on that as much. And most of my patients are also getting physical therapy. So I kind of let that to the PTs. But I think that our job often is also to make sure there's that follow through. They know what to do if they have a flare. What do I do to come back to kind of a baseline exercise program? Here are some things that feel safe to me. So those are some things. And then pain management, same thing, creating a flare kit for a bad day, talking about this huge toolbox of things that I have access to. I do custom splinting, which I never thought I would do in OT school, but somehow I have to with these patients. And so I find ways to create resting splints for them, especially that are really comfortable, and that, I try and be patient because there's a lot of issues with skin integrity and sensory issues. And so trying to manage pain and upper extremity function. And then, like we just talked about, self-advocacy and communication skills. It's a huge piece of it that I don't know that I always do as well as I could. It's an area that I'm always wanting to get better at, but it's just so important that they can walk away with feeling like they can manage their health, feeling like they know who to go to, they know how to talk to that person, they know what to do if they experience a traumatic situation again, that they, we use like mindfulness and mindful self-compassion skills, and like you can walk away at any time. You don't have to stay in an appointment. And so those kinds of things, sleep hygiene, all those kinds of things. But it is ultimately, how do I help you help yourself so that this lasts, so that you don't need me? How do I kind of work myself out of a job?
Mm-hmm. Hearing those goal areas starts to paint the picture for me of what treatment is going to look like. Sounds like there's going to be considerations about movement, pacing, joint protection, sleep. Is that kind of or I think I want to ask is, it feels like this article is pointing us to this like next level of like self-management skills. But as someone who came into this not as familiar with the condition, is there anything basic that I need to know about treatment that you didn't cover, like the traditional approach to Ehlers-Danlos, that I should be considering when I think about the treatment part of the session? You've mentioned a couple of them, but anything else to add to that?
Yeah, I think that traditionally it's been looked at pretty orthopedic, splinting, hand therapy. We need to get them stronger, and I would just challenge clinicians to really think about chronic illness, treatment, and our opportunities that we have for working alongside people with chronic illness, to really empower them rather than take away that and say, I'm going to fix you, I have this thing to fix you. But to say, what do you think will work? What have you tried in the past that was successful? Why was it successful? Why was it not? Processing, like, you have something that's not going to go away. What does that look like for you? And I loved, Sarah, you mentioned too in the introduction about acceptance. And it can be so challenging, and it really depends on in the patient in front of you, because some of these patients have accepted it to a degree that it's almost hard to be in occupational therapy, because there might be people looking for applying for disability, which I am supportive of in many cases because it's needed. And how do we toe the line of, you can be disabled and it might be really challenging for you to go back to work full time. That's, it's often an unrealistic expectation. And you can still kind of work on things at home by compensating, modifying tasks so that you have less pain, so that your quality of life is better. And so working with the patient in front of you to process some of those psychosocial elements, and I would say just to go there, to go to the hard places. And one of those hard places can be sexual function and intimacy challenges. It's one that I used to always just kind of keep on my intake, but I would skip over it. And it's one that, man, patients are so appreciative, and many patients are so ready to answer it. They're like, oh, I didn't know you did that. Yes, this is a big deal. My fatigue is so bad, or my joint pain is so bad. It's really affecting my marriage. Or so, yeah, just go to the hard places, because these patients need it, and you don't have to be an expert just to try to go there.
As much as I feel like on the podcast we talk about self-management, self-advocacy, going to these hard places. It still feels hard. And it feels like I'm left wondering, like, how do we upskill in those areas? What what's the future of treatment look like? What do we need to get better? How do we upskill? Is it just practicing having hard conversations? Or I don't know, what do you see the future ideal looking like for what we as OTs bring to the table? I think you're giving us a glimpse of it, but I'm like, logistically, how do we get there? Like, do we just need better training in all these areas? I don't know.
Yeah, I don't think it's training necessarily. I mean, I do think like continuing ed courses on motivational interviewing and there's certain topics that have been really helpful for me. Um, I think part of it is training training our students on how to treat chronic illness. I think we're going there maybe, in terms of you don't have to know the answers. I think I hear that a lot more. Students hearing that they don't have to have the answers, but ultimately, therapists, us showing students how to be vulnerable. When you said, is it just practicing having these hard conversations? I think in a lot of ways it is. It's, take the leap, ask the patient the question, and then see what happens. I think that we think people are more vulnerable or more fragile. I think we think people are more fragile than they really are, especially hypermobile patients. We talk about their fragile connective tissue and their fragile joints. And I often say, you're not fragile. If anything, you're very strong. You've endured a lot. You're very resilient. You've grit. But I do think you're vulnerable. And so what do we do to protect you? And how do we, get you the skills that you need? And so when you as a therapist I say to patients, like, this is what I know. You know a whole lot more about this than I do, especially if I didn't have EDS. How do we work together as a team? And patients just exhale, like, oh my gosh, this person isn't going to Google my condition and then tell me that they know more than I do about it. They're going to just tell me they don't know that much. I'm going to be a little disappointed, sure. Like, I would love to have someone who knows a ton, but that doesn't often exist. And so how do we just open the door for them to say, I tried this, or somebody told me this, or I saw this online, and then us to use our knowledge, our degree. We went to school for a reason. We've got a lot to be proud of, and to really use that lens. So yeah, I think that it's never going to be easy. Working with chronic illness is never going to be easy. I hope that the future of OT allows more time for therapists to have to research, to use things like OT potential to learn about conditions that they're not going to see every day, but to say, oh, I heard someone talk about this. I feel like I know enough that I can see this patient. Like, please take the patient. Don't say I don't know, so I'm not going to take them. But I hope that we can find ways to be more efficient with our documentation, and that we can have more time to prepare ourselves, and also to just like rest after seeing these patients, so that we can recuperate, and that we can help patients to be, as effective in their management of their condition as they can.
Mm-hmm. And that our reimbursement models continue to evolve, so we don't tend towards something like, I'm going to do exercise because I know how to get that reimbursed. Whereas something like self-advocacy skills are way more important, huge, bigger impact, but feels more confusing how to get that time reimbursed. Like, yes, also our payment models need to change too.
You got it. Yeah, because I can't tell you the number of therapists who have said to me, well, I don't think I should still see the patient because we're just talking, or we're just whatever. I showed them the exercises. That's all that it's like, no, I know you have so much more to offer them as an OT, making sure that we can just bill it, in a way that's going to get reimbursed. I don't have any issues with reimbursement, and I do a lot of things that are not traditional. So
Hmm.
I totally agree. I hope that our insurance and our documentation can support how important our work is outside of that.
And even in our current system, for us to be more confident in like, this is
Yes.
very valuable, what I am providing right now.
Yes.
I dare insurance to not approve this.
Yes. Exactly.
Thinking about when you're discharging patients, thinking about them being on this self-management track, what can we do to set them up better at discharge? That was something when I was practicing, I had aspirations for what I wanted to do at discharge, and it just never happened. How do you think about like the discharge process and setting patients on the self-management track?
Mm-hmm. Yeah, I think most importantly, it starts on day one, right? It starts at evaluation, that we're not promising a fix, or we're not promising that we are going to do something, but that the whole time is, as a team, we're going to help you be able to do this. We're going to empower you. I'm going to teach you skills. So I think making that thread clear throughout, it's not one day we're going to have a session on self-management, and today we're going to talk about, it's like, no, from day one, this is how this is going to go. And I also think that taking the time to have that rapport and that therapeutic alliance, to have that trust, allows patients to tell you, I didn't do the home program. I didn't listen. I don't like this. I don't think that's going to work for me. I tell patients all the time, thank you for telling me that. Because I say it's not going to do either of us any good if you're going to lie and, whatever. And so my hope is that throughout the process, we're learning what works and what doesn't work for each patient. And that then we're creating this solid foundation, so that by the time they're not seeing me anymore, that can continue to go well. I use things like sticker charts and ways to help incentivize or to help people to follow through. I ease off in my sessions. A lot of times I start weekly, and then I go to every other week, and then maybe we go to once a month or a couple of times, to say, come back in, what's not working. So I think that can help in terms of still having another visit to problem solve. And also, I encourage them to continue making SMART goals. So I say, what's important this week? Throughout therapy, every week we're going to make goals, and you're going to come back and report back on them. When you're done with therapy, I want you to still make those goals. I want you to still think about, what am I working on this week? And maybe it's not as short-term of goals. Maybe they become more 3-month, 6-month goals. But to say, how am I going to continue to progress in this way? Or how am I going to keep myself accountable? And those kinds of things. I mentioned, creating a flare kit, creating a exercise program that goes back to the foundation, because worsening or exacerbation of symptoms is inevitable. It's going to happen. They're going to have a surgery at some point, and they're going to lose, they're going to become more debilitated, or the seasonal changes are going to make them flare, the heat, the whatever it is. And so then just going in with that mentality of, what happens if things get worse? Sure, you can come back and see me, but before you get in, what are the things you're going to try? Even like, what are the things you're going to try before you go to the emergency department? Like, we know the emergency department is not going to be helpful most of the time. They're not set up for this. They are acute. And so anyway, those are, I think really playing through some scenarios and role playing and practicing scripts, and just thinking through kind of not worst case scenario, but what is likely going to happen, and trying to problem solve through that.
Mm-hmm. Do you follow the co-op approach, Emily? Are you familiar with that? The set a goal, problem solve, trial and error, come back. Are you it sounds like you, as you're describing it, I'm like, it sounds like you're doing the co-op approach.
I got trained in that, and I think that it's so,
I hear that under what you're talking about, for sure.
I would say my model that informs my practice that much is occupational adaptation, and but it's very similar in terms of co-op, because it's this idea of we try something, and we either add that to our adaptive repertoire or we go back and we say, what do I need to change? And we try that. And so that's what my whole dissertation work is on, is using occupational adaptation. But yeah, I think that I know it has to come from the patient. It can't be, I'm going to tell you what to do and this is going to work. It has to say, the patient has to decide for themselves if this is efficient, effective, and satisfying to myself and to others. That's called relative mastery. And so if they don't feel that way, this is not going to work. And so I try to just have that mentality of really just like humility of like, hey, it could work, it could not. This worked for somebody last hour, but it doesn't mean it's going to work for you. And so, yeah, a lot of revisions and I think letting patients know from the get-go that that's just how it is. You know, that's the piece of it is trial and error.
Yeah. I wasn't expecting to go this direction with you, but hearing about your practice, I can't help but ask, if I'm a patient with EDS and I'm coming to you, to be honest, what I want is for you to help me and to give me something. And as OTs, we're like, we have this powerful framework where we're going to help you find the thing to help yourself. But that's not what I came looking for. And it almost feels like we're like baiting and switching patients to be like, actually, I'm not the expert. You are. Like, how do you, does that make sense what I'm saying? And how do you guide patients through that process of coming to you for help and then they find themselves in the driver's seat, actually?
Mm-hmm. Mm-hmm. Yeah. I don't have something that works for everyone. I'm not going to tell you I haven't had patients that, you know, they didn't get what they wanted out of OT. And therefore it just kind of, you know, wasn't what they were looking for. So I've definitely had patients, and I'm, you know, I don't believe that someone should be in physical therapy for their whole life. And there are some of my patients who do believe that's the only way they will survive. And I should frame that by saying, you know, like weekly physical therapy for the rest of your life. You know, it's one thing to have episodes of care. But so I think that I try, and I don't come in strong on that first day to like change their mindset, but I drop little seeds of, you know, asking questions, because that's the best thing I can do, is to say, you know, well, so what happened? You know, it sounds like you felt better that day. You know, so, and then asking questions about like the next week or why you returned to therapy, or, you know, if especially something like a chiropractic manipulation, you know, is that really getting at the root issue? And I also think that I give them a combination of, I tell from the first day, we use a combination of adapting, modifying, compensating, those kinds of things, as well as rehabilitation. So I'm working on getting skills back and strengthening and those kinds of things. But I'm also recognizing that there are limitations, and I might not ever be able to be, quote unquote, independent in this, or, you know, in this whole idea of like a modified independent. It's like, well, if I can do it myself with a tool, then that's doing it myself. Or maybe it's asking someone else for help. And so giving them that it's okay to ask someone else for help, or it's okay to change and modify things. It doesn't all have to come from you just overcoming this condition, but can we challenge some of the thoughts that you might have about your body? That's an important piece, is can I, you know, if I believe my body is bad, my body is imperfect, those are two different things. And, you know, other people experience suffering too. This is the whole idea of mindful self-compassion. So, yeah, I don't have a really good clear-cut answer, but I think it's just a lot of conversation, a lot of processing, and bringing the same thing up many times. I'll have a great conversation with someone. They'll walk away in a very different place, and they'll come back 3 weeks later, and they want a fix, or they want, you know, me to do something to them. And I'll just start asking questions again. So it can feel cyclical. It can feel like a uphill battle, but I think it's really important work. Yeah.
I love hearing you talk, because I think about these things like theoretically, and I know that you're everyday living this in sessions. And I love to hear how you're balancing like meeting people where they are, but also headed towards this reality of self-management, which is where we ultimately want people to be able to go. And yeah, going through that cycle with them is such a great way to put it. I have one more logistical question I want to ask, prompted by this article. So much of the behavior change techniques were around education. And especially for this population where honestly the education is confusing. I'm reading it as a professional and I'm confused. What does education look like practically for you? Like, are you handing out stuff? Are you pulling up websites? Are you teaching? Like, what does that look like logistically for you in those sessions?
Yeah, this is something I was thinking about as I was preparing for this because I'm in this all the time. Like I'm constantly consuming this information and really connected with other professionals in this world. And so I'm getting the latest literature. And I think about a general clinician in a community and how hard it would be to just like have the access to the information and just give it to the patient. Like it takes time to be able to gather this. And so I think one is you learn a lot from your patients. So asking them what they already know. Two would be the Ehlers-Danlos Society is great. It is a patient facing, but also a clinician targeted organization. They have conferences and they have EDS Echo programs that have special, like an allied health EDS Echo, which is excellent. I teach in that and it's really great. But then they also have a fatigue conference and a pain conference. They have different things like that. So those are good ways to get information. I think, though, as I mentioned a minute ago, like learning from your patient, one of the best ways you can get information is to say to the patient, what do you already know? And then maybe you jot down some things and you're like, that doesn't really make sense to me, or that doesn't sound right. There might be a gap in their knowledge here. I'm going to go try and learn about this gap in their knowledge. I don't need to learn necessarily what they already know because I'm going to tell them, please this is an open communication, two-way, evidence-based practice is you and me and the research. And so I think learning what the gaps are, I obviously would love everyone to get into the nitty-gritty of like a lot of this stuff with mast cell and recognizing symptoms. And so for me, I have checklists and resources, like just so many resources that I go to because I can't keep track and remember everything. So I go pull up this resource for, symptoms of tethered cord. And then I start asking the patient, do you have these things going on, or different things that might be red flags. I have a lot of patient education that I've created. I have like handouts on pacing and energy conservation, and those are generic. Those work for my cancer patients. Those work for, POTS and many different things. So those don't have to be super specific. Joint protection is the same thing. You know about built-up handles. Your patient probably doesn't. And honestly, the other clinicians probably don't either. The physical therapists aren't taught that stuff. So they probably haven't heard that concept before. That could be helpful for them. So I think that is kind of where the generalist can try to use their time effectively and use the skills they have and the resources that they already have. And then even just taking research articles, maybe the patient read something, or maybe you go on Google Scholar and you find an article and you just highlight a few things. That can be helpful for patients. We hopefully know how to dissect an article quicker and more efficiently or effectively than a patient, to say, this is what the research shows is going to be most helpful for us.
I love getting into your clinician brain, Emily, and hearing like the researcher and the practicing clinician together. And I want to ask you a hard question to close us out. Our previous episode was on AI and documentation. Millions of dollars are going into rehab documentation skills or rehab documentation tools that are leveraging AI. they are going to have the ability to clinically suggest things to us. They're going to hypothetically be learning from all of these different EDS patients around the country. Like me as a general provider in Nebraska, maybe I'll see one or two, but there is this real possibility of really pooling data in a way that's never been before. What do you want to see built that will help your patients? Like how do you want to see this technology leveraged?
Yeah. Well, first, I think all therapists, I want to do less documentation time. I want to look my patients in the eye more often. And so I have hope for that. I have to do point of service documentation. Otherwise I don't get home until, 7:00 at night. But I really struggle with going to the computer and typing things in. So I'm hopeful for how that's going to change. I'm hopeful for quality of life for therapists and having the time to prepare for a session and to research and, to listen to an OT potential episode at work instead of always doing it on the weekends. And I'm hopeful for those things and how it can save us time and energy. And cognitive fatigue, I think too, like just freeing up some of that cognitive energy. I loved on the episode thinking about, the idea of Grammarly. I use Grammarly. I'm not going to pretend like I'm the perfect, anything that can help me to be more efficient and to fix my spelling or to put a comma or clarification, do it. Like I would love for that to happen in my documentation at work.
Yes.
And so the idea of that just being on a much larger scale and not having to think so hard about the best word to say what happened. I'm like, oh, that was so good. Now, how do I write this up? And I think OTs especially, it's hard to have a short note to say all that we did, especially in a mostly dialogue session where we're really processing and problem solving. And so I'm hopeful for that. But then for the population, I think, as you mentioned, there's so much hope for learning from what other good therapists are doing and in patient outcomes to say, I don't have time to go take this continuing ed course and that one and this one. Like there's just too many courses that you have to take unless I'm going to specialize. And so how do I learn from best practice? Because there is no clinical practice guideline for occupational therapy for EDS. There is no clinical practice guideline for occupational therapy for POTS or mast cell or these, kinds of things. So I'm hopeful for that. I think that is going to improve patient care dramatically if we can pool the data and the information. And I am also hopeful that patients are going to have more of their therapist's attention, that therapists are going to have the cognitive energy and the overall energy to be able to focus on the person in front of them instead of worrying about if they entered their hours and if they billed for the last patient and if how many notes they're having to follow up on. And and even the counting, the number of times a patient said a word, it's like, oh, that's so powerful. That could be, everybody should go listen to that episode if you didn't already, because it could do some really good quantitative stuff for us, as well as the qualitative pieces that could be captured through some really good words for insurance to say, I'm billing this and this is how I could, get this reimbursed, compared to worrying about whether or not something's going to be reimbursed. There's so much. You're
just syncing this up for me, but when I was practicing in rural Nebraska and I would see someone with MS and someone with Parkinson's, and I would just be like, what are the specialists doing who work with these populations all the time? I'm only seeing them once. And so to think of this reality where like someone, I want to know, like, what is Emily Rich doing when she sees an EDS patient, and this reality where there could be suggestions of like, here's what therapists who see these patients with a high frequency, here's the kinds of things they're doing, and to have that kind of suggesting would just be so awesome.
Yeah, I agree.
I love having episodes like this, but I'm like, there's an even more efficient way to do it, and it's coming, and I'm excited for that.
Yes.
I love talking to you, Emily. I'm so thankful that you were a returning guest. You give so much of yourself in your clinical work, in your research, and you've done so here today. What's the final thought you want to leave us on?
I think that the old model has been, I am the clinician, you are the patient. I'm here to help you, um, maybe fix you, or maybe, you know, whatever word we want to use, make you independent. And I just hope that we can really humble ourselves and recognize that the best therapist, hopefully, is the person who says, I'm coming alongside you, and we are partners in this. Let's do this together. And so hopefully that really takes the pressure off the therapist to know everything. And in turn, it really empowers the patient so that from day one, they're feeling like they have more authority, more autonomy than they ever knew. They can be need to be pivotal members of their health and their healthcare team, and which they haven't had previously. So I just hope that that we can be the leading professionals. I think OTs are perfectly situated to be the leading professionals to say, I come alongside you, and this is how we do this together.
Mm-hmm. That gift that you're giving to your patients, I'm just like, there is nothing more powerful than that we could hand them than that autonomy, that decision-making power, that sense of self-efficacy. I just thank you so much for being with us today, for giving us practical examples of what that looks like, both for this specialty or for this specific population, but just as a general approach to OT too. I just appreciate the time today, Emily.
Thank you so much, Sarah. It's so fun to get to chat with you.
Wow, you all, like I said, I am just so thankful for the opportunity to really get into the clinician brain of a master clinician like Emily, and just to her for sharing about her own lived experience with this condition. There were so many practical suggestions shared in this episode to really help you provide the best care possible to our patients with Ehlers-Danlos Syndrome. And we are going to gather all of those suggestions into a clinical decision support page in the OT Potential Club for our members to reference when you need it. And as always, I really want to hear what your thoughts were on this episode. If you are a casual listener, we would love a review from you. You can review us on our homepage at otpotential.com, and we always appreciate your comments on our YouTube video. But the best place to really discuss the implications of all of this is in the OT Potential Club, and I'll be watching for your comments in our forum. The OT Potential Club is also where you will go to earn a CEU certificate for your time today. So what you are going to do next is head to otpotential.com and either sign in or sign up for the OT Potential Club. Once you are in there, you can take a 5-question test, and when you pass, we will generate a certificate for your time today. Okay, I want to thank you so much for joining us. I hope this podcast helps keep you informed and inspired as an OT professional. Take care, and we'll talk next time.